We've been framing the whole AI versus doctor debate the wrong way from the start. I mean, it sounds simple. Compare how often a doctor gets something wrong to how often an AI does. So let's poke the bear for a second. Imagine we find out that an AI can outperform, let's say, the bottom 5% of doctors, the worst doctors. Should we roll it out everywhere? And who exactly counts as the worst doctor? Is it the person with the most patient complaints, or is it just someone who orders every test in the book for safety's sake? What does worst really mean? Meanwhile, chatbots are already out there giving people health advice that that can sometimes cause harm. And right now, there's no such thing as medical malpractice for a large language model. Nobody's gonna go to court over what a chatbot says. Well, not yet anyway. There should be stricter expectations, but the issue is that there are no clear incentives. Nobody really knows who takes the blame when things go sideways. I do think most people agree on a couple of things. AI needs to be held to a higher bar because if it messes up, it can do so at scale. Second, we're overdue for new rules around reliability. And third, matching what a human doctor would do isn't really good enough if the doctor is wrong in the first place. So, how do we even make these comparisons? People like to talk about error rates, but it's not that simple. Defining the worst doctor is hard. Even doctors who are considered weak by their peers often make only a handful of real mistakes in hundreds of cases. But then you have AI systems that, in the name of safety, will tend to overorder tests, which sounds great until you realize it explodes costs for everyone else and it slows down access for a lot of people. So you also run into this doctor concordance issue, which is a fancy way of saying, did the AI agree with the doctor? Did the AI agree with what Dr. Smith would do? But if Dr. Smith is wrong, you're just comparing mistakes to mistakes. In medicine, it's a lot easier to judge how well someone would do a procedure, let's say surgery, than to judge how well they manage long term conditions like diabetes, where it might take years to know who actually made the right call. And here's the big messy question: when, if ever, do we take humans out of the loop entirely? Some people would want a magic number. Let's say if the AI is right 98% of the time, we're good to go. But the truth isn't just about numbers. There's a whole stew of values, risk tolerance, and personal comfort levels baked in. One of the things that makes AI different is the sheer scale. If a single doctor makes a mistake, maybe a handful of patients are affected. If an AI model is flawed, it can repeat that mistake thousands or millions of times before anyone even notices. With humans, the risk is spread out over lots of individuals making independent decisions. With AI, you get this concentrated risk where one bad system can do a lot of harm very quickly. Of course, the flip side is that a good system could help just as many people just as fast. So it magnifies both the upside and the downside. And then there's a legal angle. Doctors can be sued. That's baked into the system. Malpractice exists for a reason. AI doesn't really have an equivalent yet. We need frameworks for when it's the machine that gets it wrong, or at least some kind of AI malpractice insurance. If every doctor needs to be licensed, shouldn't there be some kind of licensing system for AI models? Right now, the human who uses the AI often ends up being the liability sponge, the one who takes the fall if things go wrongly. But what happens if AI is making more and more of the decisions or even working on its own? What if the AI design is such that it's prone to overriding the doctors or the clinicians' decision making processes? What if the AI's um, integration or design does harm or limits or adversely affects how doctors make decisions? Who is responsible for that? Right? That means it's a poorly designed system. And here's a little philosophical wrinkle. How do you even define intent for a large language model? That's the questions that courts aren't ready to answer. Sometimes people suggest that the patient could accept more risk in exchange for cheaper care. But would you really want to be the one signing off on your own liability just because the insurance plan is a little cheaper? AI and humans make mistakes in different ways. AI might avoid ordinary human blunders like missing something because it's the end of a long shift, but it opens up the possibility of bizarre, unpredictable failures that no human would ever make. And when it comes to bias, humans have decades of habits to unlearn. With an AI, at least in theory, you could fix things by updating the model, but that doesn't mean it's easy. It's a different kind of problem. And at some point, not using AI for certain tasks could actually become the more risky move. If the evidence gets strong enough, say AI gets clearly better at reading x rays, it may become negligent not to use it. We've already seen, issues with front self driving cars. One car on autopilot crashes and it's front page news. But if 1,000 humans crash their cars, it barely makes a blip. We hold machines to a higher standard, whether we admit it or not. But, that's reasonable. When you get down to the real world, medicine, though, is more than just decision trees, which machines use. Doctors have to manage uncertainty, read between the lines, and handle social and emotional sides of care. AI still lives in the digital world, and if a layperson takes its confident but wrong answers at value, the human doctor is left to clean up the mess. And you'll hear people say AI already outperforms the bottom group of doctors. But in practice, those claims don't hold up yet. The way the system works now, the incentives are set for defensive medicine and overtesting, not just efficient care. Medicine isn't just a one off quiz, it's a long term relationship. How do you actually make progress safely? The first wins, I think, aren't about giving AI full control. They're about using it to direct human attention, figuring out who gets seen next, which chart needs another look, or which patient discharge needs follow up. That's where the risk is lowest and the upside is real. Real. I would say full autonomy needs a lot more evidence behind it. It also helps to make the AI's goals visible and explicit. If the system is prioritizing cost, safety, or speed, everyone, especially patients, should know. And if a clinician wants to switch what the AI is optimizing for, there should be a reason why, a record of why. Another key is to approve and credential specific versions of AI for specific jobs. Not just AI, go wild, but more like this version 14, is cleared for adult chest pain and nothing else. Each new version should have to prove itself, right? And there should be a team in charge of giving and taking away those privileges. Every model version gets an expiration date. And don't forget about the human skills. We have to keep the doctors sharp. So, maybe we schedule days where everyone works without AI or run, masked cases to check human performance. The point is to make sure that people don't lose the ability to step in if something goes wrong. And here is a real opportunity. AI can help us learn from near misses or something almost went wrong but didn't. Humans rarely spot those patterns system wide, but AI can. If you track those near misses and use them to update the model, you get safer care. Of course, that needs to be done within strict limits. So you're not chasing every tiny blip. Now let's talk about equity. There's a real risk that AI ends up filling staffing gaps in the clinics that already have the least support, meaning early large scale mistakes could cluster in those underserved settings. That's counterintuitive, right? We think that AI would be in the resource rich environments, but the need may be acute in resource poor environments and thus be pushed in that direction. And oftentimes, those environments don't have the resources for safe implementation. So you could have clustering of mistakes, errors in underserved settings. That's just something to look out for. So the answer isn't to ban AI, but to ensure that we have tighter uh, error budgets, right? Meaning we're not chasing every blip. We're only keeping those highly critical ones that there's actually human resource to oversee, right? We need to publish outcomes by site type, so it's clear what's working and where things are going off the rail. And one last thing, resource ripple effects are real. If AI leads to more precautionary testing, you see labs and imaging centers get overwhelmed. That delays care for everyone. So the system needs to monitor how much AI driven care is clogging up the rest of the pipeline and put some guardrails on it. One thing I've noticed is AI generates a lot of outputs very quickly, right? It may end up clogging the pipeline down the road if we don't take into consideration that possibility and make allowance for it, either in constraining the activities of the AI in such a way that only the valuable activities are promoted, right? Or by widening the capacity later down in the pipeline for the predicted demand. At the end of the day, there are a few things that we can all agree on. AI in healthcare needs to meet a higher safety standard than humans. We need new rules for liability. And just matching what a doctor can do is not enough, or would do is not enough, because doctors get it wrong as well. So there's still a lot up for deep debate. How do we define better than the bottom group of doctors? Does that even make sense? When, if ever, do we take a human out of the loop? Who should be on the hook legally if AI makes mistake? How do you measure competence in chronic care where feedback loops are so long for humans as well as doctors, especially when the impact of your recommendations and your activities in in chronic care can be so subtle. You advise a patient to take their medication, slight changes in diet, slight changes in empowerment of the patient, or those subtle changes over time can uh, have long-term effects that aren't immediately apparent, right? So it's how do we measure competence in that setting? What do we do about the totally weird AI failures, AI only failures that no one has seen before? So here's what I want you to take away. If AI is going to fulfill its promise in medicine, we need to start by letting it help us focus attention, not replace us. We need to make its goals explicit, switchable, approve each version for what it's proven to do, keep human skills sharp, learn from near misses, and make sure that the rollout is fair across the system. So think about it. If you need care tomorrow, would you want an AI making the call, a human, or some messy, transparent mix of both? When things go wrong, and they will, who do you trust to fix it?